So good morning, we will be starting with antiarrhythmic drugs. Hopefully you have learned about the antihypertensive drugs, anti-angiogenic drugs and some of the basic concepts about this blockers. Have you heard about beta blockers? Yes? Okay, so what these beta blockers do? They are primarily used as anti-hypertensive, anti-angiogenic drugs. Okay, so have you learned about this calcium channel blockers? Yes. So we have dihydropyridines and non-dihydropyridines. Okay, so amlodipine is the most commonly used anti-hypertensive drug. Okay, it is a DHP. Okay, what is DHP? Dihydropyridines. Today we will be learning something about this arrhythmia. Okay, so arrhythmia, the term itself will define you what is rhythm, what is arrhythmia. Okay, which is not rhythmic is arrhythmia. What it can be? Arrhythmia. What about the heart rate? Normal heart rate? 72. Something less than that or something more than that. Okay, that can be arrhythmia. When it can be arrhythmia? And the atria and the ventricle, they are not contracting synchronously. Okay, so if the atria is at lesser pace, ventricular may be at more pace. Vice versa can also be there. Okay, so that is the rhythm we are speaking about. What else can be there? There can be incoordination between the atria and the ventricle beating. Okay, what we call it as atrial fibrillation, atrial flutter. There can be just a simple arrhythmia as extrasystole. Okay, so you might have learned about the PQRS complex. Okay, PQRS, what is it? It is a single ECG wave per beat. It takes 0.8 seconds. That's why we are getting more beats per minute. Okay, so otherwise it should have been 60 beats per minute. Now we are getting 72. That means our ABN. What is ABN? SAN. What is SAN? Sinoatrial node and ABN. They are conducting at a particular pace. That pace is about 0.8 seconds. That means less than 1 minute. Okay, that's why we are getting more beats per minute. If there is some alteration in this rhythm, we are getting the problems. Okay, so we will be learning today some of the basic concepts about the rhythm. So here you are seeing the normal sinus rhythm which can be taking place at the rate of 0.8 seconds. Okay, so heart rhythm is determined by SA node. Okay, it is the principal boss. It is like a principal to the college or boss to everyone. It is the one which is controlling everything. Okay, and then we have this impulse traveling from SAN to ABN. Okay, so atrio, node. Okay, here is the ABN. Here we need to remember some basic concepts. Okay, so basic concept what we need to learn here is the electrical impulse is that which is carried out and we are measuring the electrical impulse. So as we see wires here connecting the tube lights, fans, everything. Okay, so wires are there, but in the body we have wires, we have neurons. Okay, in place of these wires we are having neurons, and neurons are basically nerve cells. Okay, how these nerve cells should be placed in order to transmit faster? How they should be placed? They should be placed end to end. Okay, and they should be having faster connection. Okay, that's how we can get the fastest. Otherwise, how it is possible that 0.8 seconds you are able to transmit the impulses, you are able to contract the atria and the ventricle. Okay, that's what we are seeing. Here, you need to remember, see, here you can see 4 people. We'll just assume the people who are sitting, 4 people on the first bench. Okay, and each of them is holding other's hand. Okay, so and now you are able to transmit a chocolate from left hand, starting from the left hand of first person to the right hand of the last person. That's how we are able to transmit. But this type of impulse may not be helpful for ventricle. Okay, for atrium it is okay because it is contacting at a slower pace. And the cells here are arranged adjacently in AVN. That means there is slow transmission, but this transmission goes very rapid. It is like 4 persons, the same 4 persons sitting from last bench, last but second bench, then third bench, then first bench. That means one bench gap is there. They are not able to hold their hands quickly. That means their hands are not reachable even when they are stretched. Now the impulse is transmitted. That means how they should do? They should give catch. Okay, so this impulses in the Purkinje fibers. Okay, you can see the Purkinje fibers here. Okay, these are the Purkinje fibers. Here the fibers are placed, cells are placed in a gap junction. That means it is given like a catch. Okay, something like that. Impulses are transmitting very fast here. Okay, so that is the basic concept we need to remember. And for ventricle, the time is only half of it. Half of it is 0.4 seconds. Okay, so SA node at 0.8 seconds and AVN should transmit in half of the time. That is 0.4 seconds. Okay, so that is the basic concept we need to remember. Suppose this AVN is bypassed. The AVN is the one which is slowing the heart rate, and if here directly it reaches it, what will happen? There will be here the AVN, SIN is transmitting at 0.8 seconds impulse, but the ventricles now are getting the impulses very fast. We know that they are working at half the speed, 0.4 seconds. That means the heart rate can be doubled. Okay, only if the impulses are transmitted through this AVN, it will be at 0.8 seconds speed. If this is bypassed, okay, if this is bypassed, it should be double the heart rate. Okay, so this AVN is the one which is regulating, because the cells in the AVN are placed like a people sitting in the first bench. Okay, that's what we are telling now. And this is seen in abnormal bundle of Kent. Okay, so there is a disease. Okay, there are various rhythmic disturbances. There are tachyarrhythmias, bradyarrhythmias, and one of them is extra neuronal connection, what we call it as bundle of Kent. Okay, that is one. Then here we need to know we have specialized pacemaker cells that can spontaneously generate the action potentials. So this action potential spreads through the normal conduction pathway, what we have told now and what we have discussed. The rate can be anywhere between 6 to 100 beats. Can you tell me some of the causes for bradycardia, physiological bradycardia? Physiological bradycardia. Have you heard of Boris Becker? Boris Becker, badminton player. Have you heard? So his heart rate was just about 40 to 60 beats. Why? I have given you a clue about physiological bradycardia. Athletics, what is happening? Due to the constant stimulation, the ventricle walls are thickened so much that within one pump, they are able to pump more blood. Okay, so that becomes physiological bradycardia. Okay, so there are so many other causes. Okay, physiological bradycardia. The first thing you need to remember is about this one. In case of this antihypertensive treatment also, there is adverse event bradycardia due to beta blockers. That's why a patient on antihypertensive drugs which are beta blockers, you should always examine the pulse rate of the patient, okay, because it can always lead to bradycardia in such patients. So any patient put on beta blockers, you need to examine heart rate, okay, or pulse rate. If it is bradycardia, you need to think about the alternative drug for the hypertension. Okay, so these are the simple factors. Any disease you know, bradycardia, one is physiological, one is drug induced. Any other thing you know? Any disease? Mixed edema. Yes? Hypothyroidism, mixed edema, you can get bradycardia. Okay. So this cardiac action potential is simple and as like any other action potential. Okay, you need not confuse between the PQRST wave and the action potential wave. Okay, it is different. Action potential wave is generated and completed within the area not the same. Okay, so it is particularly related. It is different in the common sector. It will be different for you because this is abstract. Okay, so we have this four phases. Okay, so any action, as per any action potential, we have four phases. Okay, so here is the phase 0, phase 1, phase 2, phase 3 and phase 4. Okay, so here is the four phases of action potential. Okay, so the phase 0 is the rapid depolarization. Okay, rapid depolarization. What is the normal membrane potential here? In cardiac cells, it will be minus 90 millivolts. Okay, it is always minus, kept minus. Okay, that means the cell is always kept deficient of something, and this something is in the form of ions, maybe sodium, potassium, calcium. Okay, so sodium, potassium, calcium are the positive ions which will enter the cell to make it the depolarization. Okay, so the normal polarization is always set at minus. If I tell it is minus 70, it is going towards positivity. Okay, minus 92, minus 70 means it is going uphill. Okay, the membrane polarity is disturbed. And to set an action potential, we need to bring this minus 90 to minus 70. And this action potential set is setting at that time. Okay, once it reaches the minus 70 level, the action potential sets in, and there will be faster opening of the sodium channels. Okay, that means more number of sodium ions will enter the cells. That is about the phase 0 rapid depolarization. It is rapid so that it is getting a sharp spike. You saw the graph. Okay, so it is getting a rapid spike. Why rapid spike? Because the action potential is set in and more number of sodium channels are coming. Now after that we have phase 1 early repolarization. Phase 1 early repolarization. That means the action potential, it has taken a peak, now it is in the plateau phase. For this plateau phase, the main action is to get out to send someone out. Okay, which is the most abundant ion inside the cell? That will be potassium. So now potassium is thrown out. Okay, it is a cycle now where the potassium is thrown out now. Sodium has entered in, but the potassium is thrown out, but not at the same pace. It is slightly slower, and that too in phase 1 early repolarization, it is a short fall will be there. Then phase 2, a plateau phase. Okay, in this plateau phase, there is some ion exchange that is almost equal. That almost equal can be in the form of adding a negative ion or sending out the positive ion. Okay, then we have the phase 3 rapid repolarization. In this case of rapid repolarization, okay, there can be throwing out of this calcium also. Okay, so the potassium may not be able to bring it back, and also now we are throwing out some calcium also. Okay, so first what we have done, rapid depolarization. That means sodium is coming in and the spike is got. Then we have this early repolarization. That means sodium is not thrown out now. Now the one which is thrown out is potassium. Okay, now we have a plateau phase in phase 2. In plateau phase, phase 2, what is happening? We are getting a equal status due to the slow putting out of this potassium ions, and also the calcium channels take the job. Okay, but this calcium is not that much efficient. Okay, again the potassium is thrown out. And phase 4, okay, phase 4 again a slight bit of uprise is there. Again depolarization is there. So here you can see the slide. Okay, here you can see first what is happening. So you can take this as a normal membrane which is kept at minus 90. Okay, so normal membrane which is kept at minus 90. Okay, so here you can see that there is a, here you can take this as a 0, membrane potential at 0. Here you can keep it as 90. Okay, minus 90 is there, and here you can keep it as 0, and then it can be positive here. Okay, membrane potential might have gone 10 or 20 points positive here. Okay, so here what happens in this case, here the some amount of sodium has entered, and there is setting of action potential, and more number of sodium channels are entering. That's what you are seeing here. More amount of sodium is coming inside the cell. Okay, so after that phase, then what is happening? There is phase 1. Phase 1 is early repolarization. In early repolarization, we are having the potassium which is going out. Okay, so potassium is taking a slow phase in the starting, and that slow exchange is called as phase 2. And then we have rapid repolarization. Phase 3, you can see that here more and more amount of potassium is thrown out. Okay. So this is the action potential is setting, but it should be brought to normal. It should be brought to normal means the sodium which has come in should be thrown out, and the potassium which has gone out should come in. Okay. Now, and this process is brought about by energy dependent process, and this process, energy dependent process, is by sodium potassium ATPase system. What this sodium potassium ATPase system does, it throws out the sodium, brings back the potassium. That means once the action potential is set in, you need some amount of energy to bring back the membrane potential, that is to minus 90, and this is a energy dependent process. Okay, so the drugs what we use for this antiarrhythmic agents are the class 1 agent. Class 1 agents are sodium channel blockers. Good, now sodium is not there, the first phase itself is blocked. Then we have beta blockers. Okay, beta blockers, I need to explain it with some other method. Then we have this potassium channel blockers. What happens in potassium channel blockers? Phase 2, phase 3, no repolarization, block. Then we have calcium channel blockers. Okay, the calcium channel blockers means what is happening here for this repolarization. Here it is helping. Okay. Here what is happening? The calcium which is outside, it is coming in. Okay. And also the potassium is thrown out. But it should always the potassium which is at greater levels. Okay. Calcium will be the minor factor which is acting here. Okay. So we have calcium channel blockers, sodium channel blockers, potassium channel blockers. The class 1 drugs are sodium channel blockers. The class 2 drugs are beta blockers. Okay. Then the class 3 drugs are potassium channel blockers. Okay. And the class 4 drugs are calcium channel blockers. And rest or the class 5 we have various drugs starting with digoxin, adenosine, all other drugs are. Okay. Verapamil, all these drugs are. So did you understand some basic concept? Yes? Okay. So now we will go more to this drugs. So what is this arrhythmia? So it is irregular rhythm, abnormal rate, conduction abnormality. Conduction abnormality it can be in the form of new bundle of Kent, what we told, and it can also be due to one more thing I will tell you. Here there can be a circus rhythm. What is the circus rhythm means? In case of ischemia, in case of abnormality, what can happen? This rhythm which has to be transmitted to the ventricle can get a fiber back to the AVN. That means a fiber which has entered to this Purkinje fibers can have again stimulus to the AVN. That time what can happen? Again the 0.8 seconds rhythm is altered. The impulses are more and more. That's what happens in case of ventricular tachycardias or ventricular arrhythmias, because the impulse need to be transmitted at slower rate from the AVN. But more impulses are generated. One in case of Wolff-Parkinson's type of syndrome, WPW syndrome is there, bundle of Kent is there, and also tachyarrhythmias. And we told that the repolarization process or bringing back the membrane to the normal, we always need a ATP. Okay, what happens in atherosclerosis? The blood vessels are not able to transmit the blood. No blood is transmitted means no fresh blood, no oxygen, no ATP also. No ATP also. No ATP means what can happen to this rhythm? There is no chance that again action potential is set in. Why? Because we need a repolarization to take place before the action potential is set in. If there is no repolarization, the membrane is already in positivity. Okay, we cannot have that condition. And ATP is needed, and this ATP is brought about by the blood circulating around the region. That will be carbon. So here there are three terms: effective refractory period, and absolute refractory period, and relative refractory period. Okay. This effective refractory period is the time within which the repolarization is taking place. Okay. So here you can see this whole period, ARP and RRP, absolute refractory period and the relative refractory period. Both are included in this effective refractory period. Okay, this period is minimum and is needed for the fresh action potential to start. Okay, that is the minimum time it is taking. And if this minimum time is not provided to the heart, that means more impulses are coming and bombarding the tissues, there can be arrhythmias. And most of the drugs what we are doing, we want to decrease the action potential or decrease the heart rate in case of arrhythmias. Most of the times it is tachyarrhythmias. And in these tachyarrhythmias what we are doing, we are trying to increase this period. Okay, so can we increase the ARP or can we increase the relative refractory? That will be our motto. And how we are bringing about it? It is by blockers. You need to remember all the agents used in as antiarrhythmic drugs are blockers. Okay, is it clear? The basic first concept is all the drugs used here are blockers. There is no openers here. Okay, how they block, how they bring about the action, we have learned it partially now. We will be learning it more. So if there can be extra systole, okay, that means one extra impulse has been transmitted to the ventricle. Okay, then we can have paroxysmal supraventricular tachycardia. That means atria is beating at a faster rate, but AVN is doing its job correctly. That means even though the atria is having abnormal rhythm, but AVN is acting like a shield. Okay, AVN is acting like a shield and protecting the ventricles from getting the extra impulse. Okay, that becomes supraventricular, that is above ventricular tachycardia. Now we have a condition called as atrial flutter. That means atria is contracting at very faster rate. Atrial fibrillation more than 400, 500 like that. Okay, so ventricular tachycardia, it is very difficult to save the patient. It can be secondary to the drugs, it can be secondary to the valvular abnormality. Okay, there can be so many reasons we get this atrial flutter, atrial fibrillation. Maybe in case of a block, a thromboid, which is causing this atrial flutter and fibrillation. Okay, it is most common after the stroke. Okay, when the person gets stroke, okay, there also a thromboid can come and block the heart. Okay, so these are all the different types of arrhythmias. So what causes arrhythmias? Changes in automaticity of this pacemaker, ectopic foci. Okay, that means foci other than this impulse transmission pathway. Re-entry tachycardias. That means fiber going and activating the AVN again. Okay, then we can have block in the conduction pathways. Okay, sometimes they can be block in the conduction pathways. That impulse get accumulated there and can cause abnormal rhythm. Okay, electrolyte disturbances and drugs. Okay, these can be avoided and these are preventable. In case of this dehydration also, we can get this electrolyte abnormalities. What are the drugs which can cause arrhythmias? Blockers, very necessary. Most of the antiarrhythmic drugs. Okay, most of the antiarrhythmic drugs which are classical. The classical antiarrhythmic drugs are class 1 and class 3. Okay, we will be learning it. What are the drugs in class 1 and class 3? Okay, the class 1 and class 3 drugs are the drugs which are potential to cause arrhythmia. The class 1 drug is sodium channel blockers. The class 3 drugs are potassium channel blockers. Okay, the potassium channel blockers and the sodium channel blockers and the drugs like digoxin can cause arrhythmias. So hypoxia ischemia should have this spontaneous depolarization and become a ectopic pacemaker. So this you are already knowing some things. Okay, I just brush it up. Okay, here you are telling PR interval and UP interval. Okay, this P wave onset there is for there is this normal basal phase and then the ventricle is set to motion. Okay, P wave is determining the activity of atrial. Then QRST complex. This Q wave is not normally seen unless the patient has undergone myocardial infarction. That is the imprint which has been left out by the myocardial infarction previously. If you are able to see a Q wave in a normal ECG, that means you should think that the patient has already had a myocardial infarction. Okay, this is not normally seen. And we have RST complex which is determining the ventricular activity. Anything happens to the interval, that is PR interval, that means what? atria is a disturbance. The atria is having arrhythmia. Something happened to this QT interval, that means what? The ventricular activity is disturbed. Okay. So PR interval, QT interval, you need to remember. So here, contraction of the atria, contraction of the ventricles, and repolarization of the ventricles. So the person who has classified these antiarrhythmic drugs are Vaughan-Williams Classification. So the class 1 drugs are the classical group of drugs. They are basically sodium channel blockers. Okay, basically the drugs belonging here are sodium channel blockers. 1A, 1B, and 1C. Okay, so you are seeing dV by dt. Have you seen this in your past physics? Have you seen dV by dt? V for velocity, T for time taken. Okay, so the distance traveled by duration of time taken for us. You can see that the class 1C are the drugs with marked reduction in the dV by dt. That means they are more stronger drugs. And in the first class 1A, we have moderate decrease in dV by dt. And in case of this class 1B, we have little decrease in dV by dt. That means they have varied mechanism here. Okay. All of them are blocking the sodium channels. Within that, they have varied action. Okay. This may be due to the site they block, it may be due to the duration for which they block the sodium channels. Okay. So we have three group of drugs in the drugs which blocks the